So I'll be talking about recurrent uncomplicated diverticulitis. I have no disclosures. So obviously, diverticulitis has been something that we've been deciding as surgeons when is the right time to operate for a long time. And those recommendations have come under question in the last, I would say, 10 to 15 years. Even, during my general surgery residency, we wasn't too long ago, we were still recommending surgery after 2 episodes of uncomplicated diverticulitis and surgery after 1 episode of complicated diverticulitis. So here's the statements of what we've done in the past, and I'm going to show a little bit about what the numbers are in more contemporary studies and to hopefully shed some light about what actually happens and when it actually comes back. So here are the 2 statements. Surgery is recommended after 2 episodes of uncomplicated diverticulitis, and surgery is recommended for younger patients less than 50. The rationale being that after 2 episodes of diverticulitis, that the chances of future episodes increases, that those future episodes could lead to more morbidity and complicated episodes, leading to emergency surgery and Hartmann's. And then also with younger patients that they have a more aggressive phenotype and that they could develop more complicated episodes down the road. So let's look at some of the more contemporary studies that are out there. In terms of the straight numbers of when things come back, there's actually not too many in the last 10 to 15 years. This is the best one that I could find. That was a period between 1997 and 2002. But what they found was they had 320 patients that had uncomplicated diverticulitis, and they followed those patients over 5 years. 76% of those people never had another episode. 18% had 1 more, and only 5% had 2 or more episodes. In addition, 5% of those patients went on to develop a complicated episode. So just based on that sort of observational data, it doesn't seem like most people that get diverticulitis, it happens to again. So the question of whether or not more episodes increase your risk in the future. This is a study looked at 202 patients. They divided patients into patients that had 1 episode of diverticulitis versus 2 or more episodes of diverticulitis. The only thing that they found was that the people in group 1 that had their first episode, they had a higher incidence of surgery at that initial admission. So almost 16% of those patients required surgery on the incident admission, but the rest of the numbers all looked about the same versus 1 episode or 2 or more. The failure rate of conservative management was only 10%, whether or not it was the incident episode or recurrent episodes, and the 30-day mortalities were low in both groups. For the groups that had recurrent diverticulitis, again, only 6% of those went on to have complicated episodes that required surgery. This is a study out of the group at Leahy. So this was looking at diverticulitis all comers. It was not just uncomplicated, but they looked at 672 patients between 2002 and 2008. What they found is that their overall 5-year recurrence rate was 36%, and again, their overall complicated recurrence rate was only 3.9%. The only thing that they found of significance was that the people that had complicated episodes tended to were the ones that would have the complicated recurrences. They found that to have a hazard ratio of 14.6. The factors in multivariable analysis that were associated with recurrence was a family history of diverticulitis, the length of colon involved if it was over 5 centimeters, and if there was a presence of a retroperitoneal abscess. They found that right-sided disease was associated with a lower disease recurrence rate. This was a study in British Journal of Surgery in 2007. Again, this is prospectively collected data of over 230 patients, which was over a longer time frame. 35, so about 20% of the patients that presented on their initial episode required surgery. Versus 15% of patients with a known history of diverticulitis. So again, it's the people that present with a complicated disease, it usually happens on the first episode. Of the people the 191 patients that were treated successfully with conservative management, only 9 of those patients, so 5%, required a subsequent emergency surgery, and 13% went on to get an elective resection. So most of those patients were able to be managed with just conservative management alone. This is another prospective study over a longer time frame. So this was 930 patients with 450 patients in one arm that had only one episode, and the others 484 with multiple episodes of diverticular disease. It was recruited prospectively over 11 years. And what they found was that as your episodes continue, that your chances of getting a free perforation go down. So the free perforation rate for the first episode was 25%. For the second episode was 12%. With the third, it was 6%. And then if you've gotten to your fifth episode, the chance of you having a free perforation after that is under 1%. They didn't find any patients with over 5 episodes of diverticulitis that developed a free perforation in their time frame. So that thought of, that patients, if they have multiple episodes, they'll come back to you perforated and needing a Hartman's, doesn't seem like it has that much data behind it. Looking at disease in young patients, so again, that operating on people less than 50 because they will live longer, they'll have more problems, you want to avoid that complicated episode. This was a study looking at over 1,000 patients prospectively recruited over an 11-year period. Half of those patients had had their first episode under the age of 513 patients presented with the first episode. 69 of them were under the age of 40, and 444 were over the age of 40. They use 40 as their cutoff instead of the typical, I usually find 50. And then there were 500 patients that had had multiple prior episodes. So again, there are 20 of those recurrent patients in the young group and 486 in the over 40 group. This one is a little bit easier to look at with just straight numbers. So here's their demographics. So again, you can see that there's not a whole big difference between the two groups. Okay, so the one that to look at for this group is the recurrences. That what we see actually in the younger group is that they actually have a lower chance of having recurrent disease than in the older group. But otherwise, the rest of the numbers actually look fairly similar. Here's a slide looking at, again, the various stages of diverticulitis, just trying to focus on the uncomplicated. But in the uncomplicated group, there's not too much difference in terms of the risk of recurrence or the outcomes between the young and the older groups. This was a study of 271 patients between 2001 and 2004 as retrospective. 71 patients under the age of 50, 200 patients over the age of 50. The nice thing about this study is that all of those patients had CTs. If they weren't, they were excluded from the study. So we have a better idea of where their diverticulitis lies. Again, so the table 1 all the way on the left is just their demographics. The groups look fairly similar. The older group had more chronic medical problems like renal failure, diabetes, hypercholesterol, hypertension as expected. But other than that, their initial presentations were very similar. The middle table actually is a little bit difficult to the in parentheses are the percentages of the patients that developed the recurrences. So I'll start with the top group. So of all the patients, there's 71 under the age of 50, 200 over the age of 50. Most of those were first occurrences, 75% about in both groups, 25% were recurrent. The second group that's in the conservative is the number of patients that were able to be managed conservatively. And then, so as you can see for the first episode, 89% in the young group was able to be managed conservatively versus 73% in the older group. For recurrent diverticulitis, 93%, so 15 out of this 16 up here, so 93% were able to be managed conservatively versus 83% of the older group. So again, just being younger doesn't really change your ability to manage things conservatively. It doesn't seem like they have a more virulent type of disease than in the older age group. So age alone probably is not a good indicator of whether or not you should be operating or not. Table 2 that's over here talks about the severity of their disease. And again, all of these are non-significant findings between the less than 50 and the greater than 50 age groups. So this is looking at chronic and smoldering atypical diverticulitis. This actually is one of Dr. Larson's papers. There's actually 2 separate papers from the Mayo Clinic that were non-overlapping time frames. From 1988 to 1997 was the first paper, and then this one that I'm showing you is 2005 to 2009. But these are one of the few papers that talk about this kind of chronic disease. But this one I like, Dr. Larson's paper I like because it actually put these into different categories, the difference between this chronic smoldering and atypical. So the chronic smoldering are the people that they have the pain, they have signs of diverticulitis with fever and leukocytosis, and on their CTs they still have this pericolonic inflammation or something that looks like it's still diverticulitis. To be included in that group, they had to have over 3 months of clinical symptoms, with the mean being about 7.5 months. Of those patients that got operated on, 65 patients underwent surgery, and 90% of those patients reported a resolution of symptoms. One of the harder groups to talk about are the atypical ones. These are the ones that come to your office with abdominal pain, left lower quadrant. The attacks may be like once every few weeks. It doesn't look like they're infected. You look at their CTs, you don't see the pericolonic stranding, but you might see like thickening of that colon and that post kind of like diverticular syndrome. And essentially you're operating for pain. In this study, at least for those atypical patients, in order to be included, it was 3 months of clinical symptoms with a mean of 21.9 months. There were 54 patients in this group, and 92% of those reported resolution of symptoms with surgery. So this is a group that, and I think in both papers they commented that there's a chance that if that patient has underlying IBS, which is what is leading to their initial symptoms, that they may have ongoing symptoms after surgery. So it's important to counsel those patients that although there's a chance that surgery could improve their quality of life, that it's not as clear-cut as with actual acute or this chronic smoldering diverticulitis. This is probably the best systematic review that I found. This is out of the Michigan group, published in JAMA Surgery in 2014. So it's a nice review of all the literature that's out there. So they covered over 1,400 abstracts in the review, and they included 63 publications into their review. So what they found, based on the 6 observational studies that they included in the review, that the recurrence rate after the first episode was 10 to 35%, that the recurrence rate after the second episode may be slightly increased. That was probably 50-50 in the studies that they found. But what they found universally was the severity of the attacks remained unchanged. They were a little bit also mixed on recurrence rates in younger patients. Half the studies showed a higher recurrence rate in young patients, while the other half did not, and found that it was more related to the severity of the first episode. So my take on this is that there's not really a right or wrong answer still, so I can't tell you exactly when to operate. I think that our numbers for how often we think it comes back is much lower than what we initially anticipated. So having a good grasp on what you can counsel your patients for recurrence of their diverticulitis to know the literature is important. But really it's going to focus on 2 factors. One is the patient's threshold for surgery, and 2 is the surgeon. So, in terms of the patient, everyone's going to have a different risk, how how much risk they're willing to take and the chance that something goes wrong with surgery. And when they think that their quality of life is so bad that they're willing to take on those risks of surgery, then I think that's when you operate. As long as you can give them what you think are the recurrence rates of a less than 5% chance of a complicated attack, and anywhere from a 10 to 35% chance that they're going to have another attack at some point in their life. The other part that I think is very important is that not every surgeon is the same, and especially now where in a medical environment where outcomes is so important, I think every surgeon needs to know their own outcomes. So they need to know their own anastomotic leak rate, their own wound infection, deep space infection rates, and their reoperation rates, and to some extent their length of stay. But when you can give those patients your own personal numbers, then they can weigh for themselves when they're willing to take on the risk for how bad their quality of life is. Thank you very much.